Ankara the champion, the lion is here. Zobu zobu, enyim ba master.
Toya dike, nenu dike. Toya dike, nenu dike. Iye jamara dike ruenu, ekwe chenjigo. Iye jamara dike ruenu, ekwe dagarigo. Omarunga basi, oneme kasi. Omarunga basi, oname kasi. Ebuka dike, ibe dike. Wani manaria, achaluko dike. Clear the road for Musabi. Step aside for the game changer. Onya ne kumaki aputago.
Professor Charles Okechukwu Esimone is a Nigerian professor of biopharmaceutics and pharmaceutical biotechnology and the immediate vice-chancellor of Nnamdi Azikiwe University, Awka. Professor Esimone hails from Anocha local government area of Anambra State. He attended St. Joseph's Primary School, Tiko, Cameroon from 1976 to 1982 and proceeded to St. Joseph's College, Sase, Buea, Cameroon, where he acquired a secondary school certificate in 1987. Esimone had another academic tutelage at the Cameroon College of Art and Science, Kumba, Cameroon, and obtained a general certificate in education, advanced level, in 1989. He obtained Bachelor of Pharmacy, B.Pharm, in 1995, Master of Pharmacy, M.Pharm, Pharmaceutical Microbiology in 1998, and Doctor of Philosophy, PhD in Pharmaceutics in 2002, all from the University of Nigeria, Nsukka. Professor Esimone started his career as an internee pharmacist and then became a laboratory instructor, all in the Department of Pharmaceutics, University of Nigeria, Nsukka. He became a professor of biopharmaceutics and pharmaceutical microbiology at the age of 37 years and was the pioneer dean, Faculty of Pharmaceutical Sciences, Agulu campus of Nnamdi Azikiwe University, Awka. He also served 2 terms of 2 years each as the Deputy Vice-Chancellor, Academics of Nnamdi Azikiwe University, Awka. He is a researcher with well over 100 publications and in May 2019 was ranked 18th on the list of 28 most published scholars in Nigeria. Professor Esimone has these awards and recognition to his credit: the Alexander VON, Humboldt Fellowship to Germany 2003 to 2005, Visiting Scientist to the University of Pittsburgh 2007 to 2008, the Andy Bright Contest Award for the Best African Innovative Researcher, South Africa 2009, Young Scientist to represent Nigeria at the Summer Davos Annual Meeting of New Champions Tianjin, China 2010, C.V. Raman Senior Fellowship, India 2013, Fellow of the Nigerian Academy of Science 2017, Pioneer National President of the Nanomedicine Society of Nigeria, recipient of various national and international grants, and a reviewer of several national and international journals, member of several professional bodies, including the Global Young Academy and the American Society for Cell Biology. Professor Charles Esimone is happily married to Dr. Mrs. Celestina Chinyere Esimone, who is an Associate Professor of Music. They are blessed with 5 children. Distinguished ladies and gentlemen, I present to you the keynote speaker of the 25th Annual Scientific Conference of the Association of Hospital and Administrative Pharmacists of Nigeria, Professor Charles Okechukwu Esimone, FAS.
Thank you very much. The chairman of this occasion, my boss, when our national president was describing you, I was saying, my president should not steal my job, because Dr. Eric Ifeanyi is my direct boss and mentor. You know, I made it a point of duty that wherever I go and he's there, I must tell the story from where it all started. Because I was a young researcher, lecturer at UNM, when the need, you know, to get the dean of the Faculty of Pharmaceutical Sciences at Agulu came up, and without consulting me, Dr. Eric Ifeanyi very strongly told the vice chancellor there that we don't need to look for a dean, that I already have one. And they said, who? He said, there's one person I'll bring, that is the one that can grow this school of pharmacy. I know the issue about politics. Ifeanyi knows how to play politics very well. And that's how he recommended me to the then vice chancellor. Of course, he had a very powerful tool in his hands, because he was building the Faculty of Pharmacy at Agulu that time single-handedly. So the vice chancellor needed to listen to him. And when they called me for interview and everything, of course I performed well, and the rest is history. Since I came to Nnamdi Azikiwe University, Ifeanyi has a part of our history, our trajectory, and I dare say that even my move to apply for the position of vice chancellor, I had to consult him first. And when he gave me the blessing, I now moved on. So I want to thank the chairman of today, Dr. Eric Ifeanyi, a mentor. That will make. I must recognize in a very special way our national president of PSN, Professor Cyril Odianise Osifo. You know, apart from being my professional colleague, he is also very instrumental to my progress and growth in academia. As Dean of the Pioneer Dean of Faculty of Pharmacy at Agulu, Professor Osifo was giving me both private and public support during all our accreditation and all the tutelage programs. He was a member of that faculty that many people didn't see. So I must thank you for every, support that you've been giving. I thank our national president. I must give honor to whom honor is due. His Royal Igwe Barrister J. Naji. And make a news of Puriche. No, Kaino. I make a kiss in word you because I see Igwe Negadio, Igwe Gadi, Dalwin. I want to recognize my chairman board of fellows, and by extension all the members of the board of fellows who are here. I thank my chairman. I always say that it's a privilege to be a fellow of Pharmaceutical Society of Nigeria, and that is one of the signatures that takes us to the places that we go. I thank you, our chairman, and I thank all the members of Board of Fellows by extension. I must recognize also, in a special way, our host. This great man, the chairman, national chairman of Association of Hospital Administration Pharmacists in Nigeria. Thank you so much for the wonderful work that you've been doing. When I was chosen to give this keynote speech, I was looking at my own pedigree. I said, I'm not qualified. Because this is about hospital pharmacy. I don't work in a hospital for one day. But by extension, our researches and contributions have been assisting the hospital pharmacy. And then when I saw, I got to find out the innovation that this current chairman was initiating. I said I must identify with this. As a matter of fact, I'm supposed to be on vacation now. You know, when you finish as vice chancellor of a federal university, the best thing to do is for people to give you time to go and rest for 1 year. And officially, I'm on sabbatical actually. I'm on sabbatical and I'm supposed to be outside the country on sabbatical. But when I saw the date. I said I will tarry the sabbatical and then start after this and some other events. So I want to thank you. You know that the chairman said AHAPN has living ancestors. And I want to recognize all the living ancestors of Association of Hospital and Administrative Pharmacy. I recognize all of you. I need your blessing to be able to deliver this lecture. Thanks, all of you, and I thank you so much. But I must also recognize our living ancestor in PSN, who is here live and direct. A pharmacist, Olumide Kitayo. Kabiyesi. Thank you. And my very good friend who has been supporting me, Prince Esemone, the MD of NEMEL. Thank you so much for all your support. And I thank you because today I just planned to give this lecture and then disappear. But I heard that Prince Ugu is organizing a special reception in my honor. So I'm spending the night here, courtesy of Prince Esemone. Thank you again. From Ken, I want to thank you. I didn't know about this, your title. If I've done, I'll be there at the coronation. But I thank you so much, the chairman of NAIP and all the other ESCOs. I thank you. The Secretary Board of Fellows, Ucha Pakama. I have so many colleagues here. I thank all of you. In a special way, I want to thank the LOC chairman who, many years ago, she saw something in me. She kept on telling me, talking about pharmacist Esimone here, she kept on telling me that I have potential to go places when we're coming for MCPD programs. And I dare say that she's one of the prophetess who saw tomorrow. Esimone, thank you so much. I can't recognize everybody because time is of essence. And particularly when you are delivering the keynote address, when it is past lunchtime, you must be very careful because your audience might sleep on you. But I want to assure you that by the grace of God, I will not say more than my other colleagues have said. Actually, I was privileged to be here to listen to one of the lectures by one of my students who staff that I employed and I do. I wish most of us were here to listen to that lecture by Professor Brian Obonna. It actually went beyond the keynote that we are going to give today. So that lecture should be made very public for all of us to see. It has everything that we are going to talk about today. So we will not waste time to go. I also recognize the representative of the registrar of PCN. I thank you for being here. Ladies and gentlemen of the press, distinguished pharmacists, good afternoon again. My topic this afternoon is on achieving universal health coverage, the role of Nigerian hospital and administrative pharmacists. I dare say that one of the greatest disadvantage we have as a people, as a nation, even at this time, is that we tend to de-emphasize or tend to play with issues that are of paramount importance. There is no nation that can proudly stand and boast that they are a nation when they don't take the health of their citizens seriously. And Nigeria as a nation, we don't know where we are going, whether we are moving forward or we are moving backward. But how you identify a nation that is moving forward is when you begin to look at the health indices and see how that nation prioritizes health. There are actually two, health and education, and they go hand in hand. And so when we're talking about universal health coverage, and we're looking at our role as pharmacists, our role as hospital pharmacists, our role as administrative pharmacists, I want to start on a very sad note. It's like But it's not to discourage us, it's just to stimulate us to see how important this is. It's like coming to discuss about furniture in a building that they have not identified the site to build. You don't know where the site is. You have not laid foundation, and then you are busy debating about the furniture that will be in the building. Very wrong priority. But then that tells us that all of us here will have a role to play. We have something to begin to think about. Our national president, and by extension even the chairman, said something that is very germane. I've come to realize that issues about policy, no matter how good the policies may appear to be, no matter how impactful those policies may become, if you don't know how to play the politics of bringing those policies to bear, you'll be singing, you'll be doing the dancing yourself, nobody will listen to you. Pharmacists, we need to very strategically repurpose ourselves to be at the center of healthcare politics. If you are not at the center, whatever powers, whatever strengths you have, nobody will see it, because even before you come to the table, people have taken decisions, and those decisions will begin to adversely affect us. And that's why what I'm suggesting, as we go into the lecture, I'm suggesting up front that part of our pharmacy administration, part of the curriculum, the registrar is here, part of the curriculum of our pharmacy administration in our schools should actually include a course on healthcare politics. Healthcare politics. You may think it's not important, but I'm talking from a point of practice, point of experience. Maybe need to say that as Vice Chancellor, I was trying to initiate and negotiate, and some of those in Nawood are aware here, to influence, the pharmacists being recognized as consultants in the hospital. And it became very tough, very, very tough. I had to take time, and this is live. I'm saying this on public because we need to understand how to play the politics. People were writing letters, bringing justifications, but the board of the teachers will not agree. And then I cornered, there were two members who were there. One was a pharmacist, and there was another person who was close to the chairman. I invited them for dinner, and we had about 2 hours discussion on what we need to do and what we needed to trade for us to start to be recognized as consultants. I tell you that 2-hour discussion was what changed the entire status. The only thing that made that thing not work is that the next week, that board, that teachers board was dissolved. I was not reconstituted until I left office as Vice Chancellor. But believe me, the way we were pursuing it, the political angle, not the academic angle, not the coming to showcase what you have, but I saw it as a trading that was working. And the chairman told me, the chairman of the board at that time told me, he said, if all your pharmacist colleagues were, they say VC, if all pharmacist colleagues were as reasonable, he used the word reasonable as you are, they won't have problem, there's no problem. And I said, my brother, there's no problem. It's just interest. Identify your interest, you identify my interest, we have a common meeting ground, and then we negotiate, and it goes. Pharmacists must be actively involved in healthcare politics, for policies and for pharmacy profession to go to the next level. On that note, I want to start by saying that universal health coverage stands as a beacon in the realm of global health initiatives, advocating for the principle that quality health care is not a privilege, but a fundamental right for all individuals and communities. At its core, universal health coverage strives to dismantle barriers to access and eliminate the financial burdens that often accompany healthcare, ensuring that essential services are within reach of everyone, regardless of their economic standing. The essence of universal healthcare lies in its commitment to equity, aiming to distribute healthcare resources and services fairly, with a particular focus on the vulnerable and the marginalized populations. It envisions a healthcare system where a comprehensive array of services, ranging from preventive to curative and rehabilitative care, is available to address the diverse healthcare needs of individuals. Importantly, universal healthcare emphasizes financial protection, seeking to shield individuals and families from the economic toll of seeking medical care. And this involves minimizing out-of-pocket expenses and establishing mechanisms for pooling risks, thus creating a safety net against the often crippling financial implications of health crisis. To illustrate how far Nigeria is from achieving UHC, as of 2021, out-of-pocket spending towards healthcare in Nigeria was 76%, which was a stark contrast to Ghana here, where out-of-pocket spending towards healthcare was 27%. You can imagine 76 against 27%. That's how far we are from realizing that. Comprehensiveness is another hallmark of UHC, extending beyond the treatment of specific diseases to encompassing holistic well-being and the consideration of social determinants of health. The quality of care forms a cornerstone, advocating for services that are not only effective but also safe, patient-centered, timely and efficient. All these were enumerated by the plenary speaker this morning. Now, government plays a pivotal role in the realization of UHC, as their commitment is essential in formulating and implementing policies that bolster healthcare infrastructure and human resources and financial mechanisms necessary for universal access to health services. UHC is not only a national agenda, but it's a global one, endorsed by organizations such as the World Health Organization and integrated into the Sustainable Development Goal SDGs of the United Nations. In essence, UHC aspires to create a healthcare landscape where no one is left behind, ensuring that health is not determined by socio-economic factors. It embodies the conviction that health is not just a medical concern, but a human right concern. And that's where we should target. It's a human right concern, and achieving it is a moral imperative and a catalyst for sustainable development. That's why the UN is involved. That's how they see that as a human right concern, and that is a moral imperative for us to accomplish it. Universal health coverage is a broad concept, and various models exist worldwide to provide healthcare coverage to all citizens. Now, some types of universal health systems that can potentially ensure that everyone is in a jurisdiction is covered for medical hospitals care. They include, number one, required health insurance. Now, certain governments enforce compulsory health insurance for all their residents. And so penalties for they give penalties for non-compliance. While subsidies may be provided for premiums, most insurance is offered by private firms, and this is what is obtainable in countries like Germany. So in Germany, for instance, both for profit and not-for-profit insurance operate within the system. And this mandatory insurance approach has contributed to achieving universal health coverage in these countries like Germany, the Netherlands, and Switzerland. The data of Germany is very, very strong and it's composed. As a matter of fact, you can't stay there except you have insurance coverage, and it's provided by the private sector. They do that very well, but government ensures that this is mandatory. It's a condition for your living there, condition for your coming in there. Very, very, very important. There's also the single payer insurance system. Now in this system, the government covers all healthcare expenses through tax revenue, enabling countries to regulate costs by having the government take a more active role in negotiating healthcare prices. Universal health insurance is provided by a single entity. However, healthcare services are delivered by private sector doctors and hospitals. This is what we find in countries like Canada and France, where the private sector insurance exists, but they serve mainly as providers of supplementary coverage. There's also the national healthcare system. In such systems, the government is responsible for both insurance and medical services. For instance, in the United Kingdom, the NHS, National Health Service, the government owns the majority of hospitals and they employ healthcare professionals. And similarly, you find that in Sweden's publicly funded system, where primarily they deliver healthcare through government providers, with private entities having a minor involvement. And this is what we describe as socialized healthcare system. They are less prevalent compared to single-payer systems. Global initiatives and commitment to UHC. Since 2010, the World Health Organization has advocated for UHC as a global health and development priority. These two things are important. They see it as a global health priority. They also see that as a development priority. So it makes it easy. These two things work in synergy. So USC has been endorsed by the World Bank, and so it has been integrated in the United Nations Sustainable Development Goals as a specific target, what we call target 3.8, which is to achieve universal health coverage by 2030. So identifying this, the UN has therefore identified this as both a global health and also a development priority. The trick here is that once the UN identifies something as a development priority, they give it a lot of support. And that's why some of the fundings are coming to a lot of third world countries, because they're priority. Since the WHO advanced the case for USC in its World Health Report on health system financing in 2010, there has been a great upsurge of demand for advice and assistance about how to deliver UHC. And a growing number of countries across the development spectrum, that is whether first world, developed, or underdeveloped, all of them, they have been working towards UHC. And so UHC is currently seen as a key component of achieving sustainable development goals, and it is emphasized as a means to provide all individuals and communities with access to quality health services without suffering hardship. Additionally, the Beijing Initiative on December 4 to 5, 2023, just last year, they call for all countries to develop high-quality primary health care, which is the most effective way to improve people's health and well-being. The idea here is that primary health care services act as the cornerstone of a resilient health system. And we know that, universal health coverage is all founded on primary health care. And so any nation that does not have a vibrant, functional primary health care may not be able to attain the goals, the objectives of universal health coverage. And that's where we have strength as pharmacists, to function at the primary health care service. Because that's the foundation, that's the backbone of universal health coverage. Let's look at the current status of universal health coverage in Nigeria. Currently, Nigeria faces significant challenges in achieving universal health coverage, despite efforts to improve healthcare access and delivery. The current challenges are summarized below. Number one, healthcare infrastructure. Nigeria's healthcare infrastructure is inadequate, particularly in rural areas with limited access to healthcare facilities, medical equipment, and skilled healthcare professionals. Many health facilities lack the essential resources and are poorly equipped to meet the healthcare needs of the population. There's a lack of robust and effective surveillance system, resulting in the absence of mechanisms to monitor the occurrence of communicable diseases, bioterrorism, chemical poisoning, and other public health threats. Recently, we're involved in a multi-country grant, multi-country grants of worth over, $200 million. So a couple of us are representing Nigeria. And it was very embarrassing at the point where they needed basic data about, the emphasis was on antibiotic, antimicrobial resistance. We're trying to look at antibiotic, antimicrobial stewardship. I tell you, it is strange, and I'm happy that we're here talking about this. You will visit, some hospitals, and I don't know, I wanted the chairman of, AHAPN to be here. Antibiotic, antimicrobial stewardship programs that you will find as a basic working group in many hospitals around the world, even in some parts of East Africa, nations like that. It was difficult to get data. I mean, we cannot tell lies. We can't say what does not exist. You don't force those things to exist. We're looking at baseline, and it was lacking in many of our hospitals. People don't know about that. And you see, if you restrict yourself to traditional dispenser, people come, you count tablets and give. That's how you'll be addressed. We need to be more innovative and be involved in things that's why we say we need to do the politicking. How will we not have, stewardship programs in our hospitals? You develop that and you make sure that, as the chairman said, as the national president said, so when they say there's just one seat, you take the seat there. You say, who will be the chairman of this committee? Pharmacists say, I will be the one, because it has to be about drugs. And then later on, let the doctors, consultants come and join. You make sure that you are the one who is in charge. So that study, showed a lot of gaps that we had. But then, that's why we're doing the study. We identify gaps, and then we'll see how we can make recommendations for treatment. Again, there was another part of the study where they were trying to document, and this is also sometimes what we have as strength will allow you to go by. Now they were trying to document in some parts of Asia, Southeastern Asia, they have been able to document indigenous practices that were contributing to healthcare coverage. It's part of universal health coverage. Everything must not be about essential drug use. No, there are places where indigenous practices, even in childbirth, even in gynecology, even in treatment of diseases, have been shown to be effective, like in China and India, and have been able to document these things, and now people are now trying to study that. We told them that we have such in Nigeria, that we have traditional medicinal practices that are good, that are also effective, that we can subject to empirical evaluation, and they'll be good. So we needed to get better. Again, we have issues. Issues because some colleagues already have this bias. If we want to talk about science should be empirical. You come with an unbiased mind. Let's evaluate this, head to head. I took a couple of my staff, went to China sometime, I think late last year, July last year. Now we went to China at Papa University. And there, a medical doctor was there. Actually, the chief medical director of our hospital was in that team. I said, okay, come and see. In China, they have a big hospital, very big, multi-billion-dollar hospital, where all they do there, they are doing is orthopedic and traditional medicine, but they are all standardized and they are accepted. So patients can choose, want to go orthodox or want to go, but it's standardized, regulated, automated. So why is it that when we come here, we say we want to introduce this in your hospital, We say, let us have a section where we're going to do, this is our strength. We have strength in this area. Somebody say, no, all these local things, we don't want them. Local things, when you call your own local, it becomes local. Yes. Chinese people say their own is international, they're exporting it everywhere. So in this grant, was to document evidence of that. So we call some people together, and then so when they wanted to do that, I said, no, I don't want that politics of, let us be open. If these people have technologies that we can evaluate, that we can subject to empirical proof, let us put them. They will help cover the rural communities better than the essential, because how many doctors do we have in Nigeria? How many people are willing to go to those, some of those? Because universal health coverage is more about those who are vulnerable, where access is limited. So how do we accomplish that if our indigenous technologies and those who could provide this are shut out? So this is one of the problems. Infrastructure is bad, but we have a strong advantage that we can capitalize on. We need to think outside the box and begin to use this for our own advantage and not to our disadvantage. There's also the issue, challenge of healthcare financing. The healthcare financing system in Nigeria is fragmented with a large proportion of health expenditure being out-of-pocket payment. This is one of the greatest issues. And this is how we assess a nation that is moving upward in the health ladder. How are people financing their healthcare services? The National Health Insurance Scheme aims to provide financial risk protection. Still, its coverage remains low, with challenges in enrollment and inadequate funding leading to sustainability issues and concerns about the quality of care provided under the scheme. A recent survey, this was a survey that was carried out among residents in Lagos, it showed that about 90.5% of the study population, they had no health insurance plan, while only 5.6% were enrolled under the NHIS scheme, and 3.9% were enrolled in the private health insurance scheme. This was a study that was carried out, study in Lagos. The publication will have the references. Number 3 is health service delivery. Healthcare service delivery in Nigeria is characterized by disparities in quality and accessibility. Now, while urban areas have better equipped facilities and skilled healthcare professionals, rural areas often lack basic healthcare services. There are shortages of healthcare workers, including doctors. Now we're having doctors and nurses and pharmacists involved in Japan syndrome. So we don't have, and there is mass exodus of the little ones. So we're in trouble. Only God will help us in Jesus' name. And pharmacists, resulting in overcrowded hospitals and long waiting times for patients. According to a Lancet report that assesses health system performance based on criteria such as healthcare access and quality, Nigeria is ranked 142 out of 195 countries. Those are empirical evidence. Number 4 is disease burden. Nigeria faces a high burden of communicable diseases such as malaria, tuberculosis, and HIV, as well as non-communicable diseases such as hypertension, diabetes, and cancer. The healthcare system is strained by the double burden of disease, further exacerbated by the challenges of COVID-19. As reported by WHO, Nigeria grapples with high burdens of communicable and non-communicable diseases, the latter causing 27% of deaths in 2019. While child survival rates improved from 2015 to 2021, the country has not met Sustainable Development Goal targets. So Nigeria faces endemicity for 4 of 5 neglected tropical diseases, with 84% treated through mass drug administration in 2020. Now, vaccination coverage rates for children remain suboptimal, with only 56% receiving the 3rd dose of DTP and 59% for the first dose of measles vaccines in 2021. This leads to 3.9 million under-immunized and 2.3 million zero-immunized children. Now, we can't believe that this is happening, but it's true. We have a large proportion of this, our children who are zero-immunized, and about 3.3 million from these statistics of 2021 who are under-immunized. Now, healthcare governance and policy. Governance and policy challenges, including weak health systems, inadequate regulatory framework, and corruption, hinders progress towards UAC in Nigeria. There is need for strengthened governance structure, effective policy implementation, and accountability mechanism to improve health care delivery and ensure equitable access. Now, people talk about governance, but I also realize that the issue is not just about governance structure. No, recently, sometime in May, I had a meeting with Aliko Dangote. I went for another thing altogether. He invited me, and in the course of our discussion, when he discovered that I was a pharmacist, he now posed a question, and this question and also is part of the challenge we are talking about. He said, "Professor, I have a hospital. I want to contribute in universal health coverage, mass production, giving the less privileged to have access to drug." That he had this big hospital in Kano, that even in that setting, he discovered that those drugs, that he thought to be for the less privileged, that some big politicians, they will send their mothers, tell their fathers, send their wards to those places, and they want them to have access to those things. And when they come, he has given criteria for those to have access. And they will bypass all those things in the hospital. A senator will come and they will just pack all the family, and then the vulnerable, the less privileged that need this medicine, they will stand there waiting, they won't get the drugs. He was asking me, how do we solve the problem? So I'm throwing back to you now, how do we solve this problem? This is not about government. This is private sector that wants to give back, wants to contribute to UHC. And the structure, there. So the keynote, the plenary speaker in the morning said, it's a question of corruption. So I don't know how to deal with corruption, whether to cut the hand that is involved in corruption or to close down the system. But it's a problem, that's what is affecting us in Nigeria. Now I'll quickly round up by looking at the role of hospital and administrative pharmacists in achieving UAC. The role of hospital and administrative pharmacists in achieving this. So look at the hospital pharmacists because of time. Now, hospital pharmacists play a role in achieving UAC by ensuring the safe, effective, and efficient use of medications within the hospital. Number one, they do this by, there are 5 important areas. Number one is medication management and safety. Hospital pharmacists are responsible for managing the medication from the beginning to the procurement process and the storage to dispensing and administration. They conduct medication reviews, they ensure appropriate prescribing practices, and therefore they monitor for drug interaction. Number 2, they optimize treatment outcomes. They do this by providing evidence-based recommendations on drug selections, on dosing, and monitoring tailored to individual patient needs and treatment goals. Number 3, they provide clinical pharmacy services. They do this by providing direct patient care through clinical pharmacy services such as medication reconciliation, therapeutic drug monitoring, and medication counseling. Number 4, they also assist in transitions of care, those moving from one health facility to the other. They play a crucial role in managing transitions of care, ensuring continuity of medication therapy as patients move between healthcare settings. Not only that, they are involved in quality improvements and patient safety. Hospital pharmacists contribute to quality improvement initiatives. They do this by participating in medication safety committees. They conduct medication-related audits and assessments, and they implement strategies to minimize medication-related risks. And finally, they are involved in education and training. They provide training on medication use, drug information, and pharmacotherapy. They also ensure that healthcare providers have the knowledge and the skills that are necessary to deliver high-quality services. Importance of administrative pharmacists in achieving UAC goals. Number 1 is they involve in resource management. Administrative pharmacists are responsible for managing resources effectively, including medication inventory, staffing, and budgeting. By optimizing resource allocation, they ensure that essential medications are available. Number 2, they also provide quality assurance and regulatory compliance. Number 3, they provide strategic planning and program development. This is very important in our hospitals, and administrative pharmacists are involved in that. Like what I talked about antibiotics stewardship, such programs should be planned by hospital pharmacists and by administrative pharmacists and integrated in the hospital system. Number 4, health information technology. Hospital administrative pharmacists are also involved in this. They streamline pharmacy operations and enhance medication management processes and support clinical decision making. Again, they also provide patient advocacy and education, as well as interdisciplinary collaboration. Administrative pharmacists should be able to network this, and this is where the politics come. The interdisciplinary collaboration. The companies need to see your strength in this area, and then they will give you a right place. In conclusion, because of time, universal health coverage stands as a beacon of hope in the global pursuit of equitable access to quality health care for all. As outlined, universal health care encompasses comprehensive health care services, financial protection, and quality care, with various health care models existing worldwide to achieve its goal. Despite the challenges faced by countries like Nigeria in achieving universal health care, the pivotal role of pharmacists, particularly hospital and administrative pharmacists, cannot be overstated. Their contributions to ensuring safe medication use, optimizing treatment outcomes, and advocating for patient-centered care are instrumental in advancing UHC objectives. Moreover, the institutionalization of clinical pharmacy and the development of community pharmacy practice offer promising avenues to address gaps in healthcare delivery, particularly in resource-constrained settings. By overcoming barriers such as limited awareness, resistance to change within the healthcare system, and regulatory restrictions, stakeholders can harness the full potential of pharmacists in enhancing healthcare access and quality. In essence, achieving universal health coverage requires concerted efforts from the government, from healthcare organizations, from educational institutions, and stakeholders to address systemic challenges, promote collaboration, and empower healthcare professionals to meet the diverse health needs of population. As we continue to navigate the complex landscape of global health, the pursuit of universal health coverage remains not only a moral imperative, but also a catalyst for sustainable development and improved well-being for generations to come. I thank you for your attention.
Thank you. A round of applause.
It is on behalf of the Association of Hospital and Administrative Pharmacists of Nigeria that I want to convey this appreciation, this certificate of appreciation to you for not just delivering a stimulating keynote address, leading information, but of course an address that is grounded in a comprehensive reform agenda for this aging and sinking health system. Professor Esimone, the truth, we are proud to have you as one of our golden voices in this profession. You remain definitely, in fact, I think you've been escalated to the pedestal, not just a pharmacist. You have become a shining metaphor of all known nationalistic idioms. And you know, I speak from the heart. If anybody has done well, let us position them that they have done well. Somebody said Professor Esimone was at one time the youngest professor we ever saw in pharmacy. That is great. But one of the things you do not probably see is that he's also one of the few pharmacists whoever emerged as vice chancellors of federal universities. So I think I have a very good idea of what I am saying. We celebrate you, and we will of course celebrate you even more, much more better than what we are doing here today. So without wasting too much time, let me present this to you on behalf of our people.
Step aside for the game changer.
I wish to present this to you on behalf of all the AHAPN people here as the keynote address speaker. You spoke so well. I was taking notes, but towards the end, when you got to the recommendations, I got lost. So when my friend here said there will be no exams, I felt relieved. So on behalf of all of us, this once again a show of appreciation. This 7th day of August 2024, Professor Charles Esimone.
Congratulations.
Association of Hospital and Administrative Pharmacists, bedrock of the profession. So when they approached me to deliver this keynote, I was very glad and obliged them. Secondly, the issue of universal health coverage is a very big problem, and as a nation, we needed to be challenged to see how far we are from federalization. Is very important. Importantly, to identify the role of pharmacists. Pharmacists are supposed to play a pivotal role in the healthcare delivery in the nation. They do so in every other part of the world. In America, in Asia, in Europe, pharmacists are very central. But in Nigeria, we seem not to realize that we have a particular important role to play. So I wanted also to challenge my colleagues, the professionals, and also to use the opportunity to draw the attention of other healthcare professionals and also the government in general about what role we ought to play, and that unless we are granted that opportunity, they will be far from accomplishing this very important goal of universal health coverage, which of course is primary health care. Again, it goes to the issue of giving honor to whom honor is due. Drug abuse stems from two important factors. Number one is misplaced priority. A lot of the services in the healthcare system is being usurped by those who are more or less, I would say, quacks, those who are not the professionals. So pharmacists need to be in charge of in charge of drugs everywhere. Even those who are other professionals in the healthcare system tend to be involved in drug abuse because they don't have the knowledge. The pharmacist is the only professional that is trained to educate and also to listen about drugs. But because this information is not well situated, so you see that people are involved in that. So government has a particular important role to elevate pharmacists to where they are. Now we're talking about plans for pharmacists in the hospital. The government should accommodate that, because if we're not consultants in something that we are the experts, who else should be the consultant? So we see that fundamentally government should be able to educate us and give us a, and then also the infrastructure that is needed to develop the professionals should be strengthened. Because if you don't have good infrastructure, if you have infrastructure that is deformed, that is divisible, or that you train hard big pharmacists, and not there, the massive exodus of professionals outside the country is also creating a very big gap in the healthcare system. So government needs to strengthen that by proper welfare package for pharmacists as done other places, so that people also leave other countries and come to Nigeria to practice. I think that's how it was in the early 60s and the early 70s. People were living in India and they are coming to Nigeria to practice. because it was more lucrative. So if you create that lucrative environment, the welfare package will offer it to them. Finally, we need to also tell ourselves the truth, because in all our states and cities and everywhere, we have a lot of emphasis on the product, not the process. The process is very important. We need to look at the process of training, the process of education, the process of developing, whatever product that you have. When people look at the process, the abuse will not be there again.